Good, good. How are you?
Fine. Oh, traffic was, I heard there was,
Places where the center lane was.
yeah.
Oh, you're doing what? Channeling? Oh, yeah, that's really great. Good afternoon. Welcome to the second meeting of the Advisory Council. I'd like to thank everyone for coming today and braving it through the traffic here. I'm hearing that was a little difficult. And thank you for so many good thoughts from our first meeting. I felt our meeting went well last time, but you never know what other folks think. So we did get down to the legislature the next day, and folks who were talking about what we were doing at the legislature also thought we had a good meeting. So thank you. Just before we get going, most of today's meeting will be facilitated, not too much presentation from us, and really more facilitated conversation. But before we get straight into that, I wanted to just have everyone go around and have everyone introduce themselves. And we do record our meeting, so just so that one of the things when we are introducing, and we also have folks on WebEx, we do record our meetings, and it's really helpful as we're listening to make sure we understand what people are saying, that we can hear who's here at the meeting. So, and I'm Donna Kinzer from HSCRC.
I'm Jack Meyer. I'll be facilitating today. I'm in the D.C. Office of Health Management Associates.
And I'm Carmela Coyle with the Maryland Hospital Association.
Kevin Sexton from Holy Cross. Vinny DeMarco of Maryland Healthcare for All Coalition and Consumer Outreach Task Force.
Peggy Nalepa from Peninsula Regional Medical Center and Health System.
Tim Sancona, Amerigroup Maryland.
Lenny Preston, Maryland Women's Coalition for Healthcare Reform and the Consumer Engagement Task Force.
Willarda Edwards, Internal Medicine, Private Practice, and past president of MedChi.
Gene Ransom, I work for MedChi.
Eric Wagner, MedStar Health.
I'm Joe Ross from Meritus in Hagerstown.
David Blumenthal from the Commonwealth Fund in New York City.
Ben Steffen, Maryland Healthcare Commission.
And
and I'm Tom Walsh. I'm from Maryland Primary Care Physician.
And on the WebEx we have. Oh, I'm sorry.
And I'm Joe Matos. I'm with the Health Facilities Association.
And on the WebEx we have.
This is Bruce.
This is
Gary Simmons.
Go ahead, Gary.
Gary Simmons, United Healthcare.
Dean Farley, former public member of the HSCRC and Vice President at Optum.
Bruce Vladeck from New York Nexair Inc.
Well, thank you, everyone. And I think we can turn it right over to Jack.
Well, thanks for everyone for coming to the second meeting. We have a lot of ground to cover, and I'm eager to hear from all of you. We're also, toward the end, Vinny DeMarco is going to tell us about his wonderfully successful gathering of the faith-based community against all the weather gods. People who stayed home from everything else still came to Vinny's gathering, and he has a few slides that later in the day we're going to have him walk us through, and then we will have a public comment period for our friends in the back of the room who have thoughts. So what I want to do is I'd like to start with recapping the themes and key points from our last meeting. I just thought it would be helpful to tick off a few points, a few takeaways that I came away from the meeting from as I kept going back over the notes. And it's by no means exhaustive, and it probably isn't fully accurate, but it's just a jump starter, a conversation starter. You don't need to write them down. If you don't remember a couple, I'll repeat them, but it's just to kind of refresh you with some of the points that seem to stand out to me. But that's just a starter, and then you'll add to and take away and come up with different ideas. But I thought it would be helpful to see what we concluded last time and then build on that to develop some next steps and strategies to help HSCRC meet its goals. So here are the ones I have. I'll go slowly, but as I say, no need to write these down. One of the most consistent points that came up again and again was to focus on a few realistic and achievable goals. One person said, don't be too global. I kind of summarized it by saying, colloquially, instead of doing a lot of things a little, do a few things a lot. But that came up again and again. Be focused. A second thing was, and related, is to avoid a scattershot approach. Don't spread ourselves too thinly. And Bruce Vladeck reminded us it might be helpful to keep a running tally on where we might need support from the federal government. And a third point was where we find that community-wide or regional collaborative efforts are proving to be promising or actually in a documented way successful, figure out ways to bring them to scale around the state. Another point was that two challenges that also came up that were highlighted. These are not new, but again, consistent with we can't do everything, but it seemed like the group felt that two good bets would be to focus heavily on physician alignment and post-acute care. Those two things seem to be more front and center, even though there are many other challenges. And improving post-acute care by bringing IT infrastructure into that world. And there was some emphasis on medication management and reconciliation in that world. It's always a challenge, but particularly important in post-acute care. Another challenge was how to tie the patients with complex medical and social needs to their physicians. We need to not only do that, but the physicians need to know who they are, and there was a good bit of talk about making doctors aware of their eligibility for the CCM, or Care Coordination and Management fee, increase their take-up of that payment from the federal government, and even some talk about what might be the burden of the co-payment, modest as it may seem in absolute terms, but for some lower income patients, and finding a way to give them some relief. Producing for primary care physicians the risk stratification of their patients and help them figure out what supports they need. Although there was a lot of emphasis on the primary care physician world, Peggy reminded us of the overwhelming constellation of things that can come up with a hospital. And although we've probably talked about each one in some way, to hear her describe all of them at once 7 or 8 of them was really quite compelling, and I think Ram reminded us not to forget about specialist physicians and even a surgical medical home that he's working on. And I think it was Bruce that noted that a lot of the 40,000 people that we were focusing on in the Medicare fee-for-service world with complex needs have behavioral health serious issues, and yet that system, as he reminded us, is underfunded, not only in Maryland but elsewhere, and he highlighted the PACE program and so on. Just a couple more. One theme was, I wrote this down and then scratched out a word in the interest of civility. Give us the data already was a theme that several of you, I sort of had an adjective in front of data. I did, yeah, you can see what it was. I try to run a very, civil ship. Accountability throughout the system, all the players, and Kevin reminded us to cut down the time of getting good ideas to the market, which is really important. He also had some other thoughts, which maybe we can get him to repeat, about using both top-down and bottom-up approaches. And the final point is kind of, this is sort of to be truth and disclosure. It's kind of one of my takeaways. It sort of was there in the meeting, but this is sort of my idea, so I'm not attributing to you. But that is to, continue the excellent working relationship with CMMI and other parts of HHS that Donna and her team have built up. That may sound like, well, why wouldn't you? But this is the time in the political cycle when people are leaving of the federal government. Some have already left. Some are leaving as we speak, and some are circulating their resumes. I'm talking about high-level people, although, mid-level people are important too, but there are going to be some new faces and new hats, regardless of who wins the election. And Steve Jenks at the last meeting, sort of in closing, reminded us of the importance of the all-payer nature of what CMMI is interested in. We know how interested they are, and there's a lot of money at stake for this state in maintaining them in the federal government in this. So that's it. I'm sorry it took a little longer than I intended, but those were some of the things I heard. I'd be interested in what you think some of the major themes and conclusions, or maybe conclusions is premature, themes, principles were, and of course bring up some that I didn't mention. Peggy.
I appreciate the discussion around the data needs and your statement of the proper language, but I felt like it was slightly understated in the themes, because it's a significant lever in our process, access to and our ability to analyze and have the much deeper dives with the data analytics to be able to identify, and we have it listed here under Medicare, but when we look at Medicaid and the dual eligibles and the high-risk populations, that's not necessarily just the Medicare. So I absolutely think we need to focus on that as a key lever. That was a theme that came through in addition to the Medicare discussion, and emphasize that on an ongoing basis, because it's critical to our success. Our ability to hot zone and be able to identify those chronic care management populations, et cetera, is a key to the total cost of care. But I felt like it was a little understated, yeah, and perhaps if we could strengthen that.
Fair enough. Good point. It was understated perhaps and too narrow, and I take both points. Thank you. Other thoughts, comments about, I don't know, prioritizing, and David, you brought this up at the first meeting 2 years ago, actually, and I think the metaphor you used was letting 1,000 flowers bloom, and that while we usually think of that as a good thing, it can sometimes not be so good if you're too scattered. So setting priorities. Carmela, yeah.
If I could, because the things you just outlined are exactly the conversation I remember. And I wonder if it's just an opportunity to integrate that into the slides. Because I think the points in the slides are helpful in terms of the themes from the discussion. But I think we should add those you just said here, you know, the few realistic goals, avoid a scatter shot. I won't go through them again. But I thought your notes there really captured the last conversation, including the data issue that Peggy just raised.
Well, thanks. Yeah, there's a lot of great information in the slides, and I wasn't trying to sync them up, but you know, we will sync everything up, and I appreciate that. Other things that you came away from the last meeting, or that you know, or that you think are really important, whether they came from the last meeting or not, that you want to make sure going forward, particularly in identifying patients with the most complex needs, figuring out ways to bring this to the attention of their primary care physicians, their specialist physicians. IT is a part of this, getting the physicians into the CRISP source and using it, getting information on their patients in real time, their problem list, their medication list, the kind of things that are in a care profile, in standardized, or getting their consent, you know, and then, you know, in a more customized way, coming up with care plans, which will be different for every patient. Any ideas you have on that, or other ways, what sort of infrastructure might be needed to serve hospitals, physicians, long-term care providers, and so on? It's easy to talk about these things, but people say, well, how do I do it? And, you know, what do I do first? What do I do second? Yeah, Vince.
Jack, this is Dean Farley.
Oh, hi, Dean.
With the disadvantage of being on the phone is you can't see hands, but I'd like to have something to say here in a minute.
Please. Right now.
Okay.
Fine.
You know, as I was thinking about the meeting over the last couple of weeks, I kept coming back to a question that Chet raised about accountability. And the fact that I'm continuing to struggle with understanding what the chain of accountability is here. And I think it's sort of a key piece to how the framework comes together. I mean, there are sort of pretty substantial financial incentives involved at the state level. And you know, Chet's question was who's accountable, whose ox gets gored under different circumstances. And I think being able to articulate and understand how the pieces fit together goes a long way towards clarifying the incentives that are going to be available within this system, who's taking risk, and you know, if there are financial shortfalls, for example, where's that money coming from? And I think understanding those incentives will help the system and help the state sort of figure out where who's going to take responsibility for figuring out what the flowers are that are blooming. And I realize this is not an easy question. I realize there's probably some controversy around it, but I think we need to do more about sort of laying out those incentives as a key part of the infrastructure.
Good. Thank you, Dean, and Vince, I'll come to you in a minute. In fact, if you have a comment on that, or since
it's nearly the identical comment.
Perfect.
So
segue.
It's essentially that accountability part. How do you attribute members or patients, those that aren't seeking care? Who's going to reach out? The risk part of things. So I would echo all of those comments.
Other thoughts about accountability? I mean, you know, my sense is that it's not that we search around and identify one group and say you're accountable. It's sort of like we're all in the same ship here. And how do you knit the players together in some way that they're mutually accountable? But I'd like to hear from you on this. I'm glad Dean brought it up, and thanks, Vince. Izzy.
I think a sure way to create mutual accountability is to align incentives and how providers and how all the players are paid. Right now, it's not aligned. In fact, in some ways, it's conflicting financial incentives.
Yeah, sort of cries out sharing of the gains.
Right.
And as well as the risk.
The penalties.
Yeah. Well taken. Other thoughts on how we do that? You know, what are some priority areas to have everybody have some skin in the game, but also some sharing of the fruit if we do it well? What would be the things we'd place our bets on to make that happen? Some of it may be getting certain legal and regulatory authorities to share gains. Others of it is more cooperative relationships. But I'd be open to your thoughts about how we, you know, given that that Donna, in such an amazing fashion, organized the hospitals in record time at the beginning of this innovation grant into revenue caps and a whole new system of accountability that went beyond cost per discharge toward responsive accountability for total hospital cost per capita. Okay, that's great. And those of you from the who are hospital leaders here, and there's several, are work in that world. And I guess the question is, how can others join you, get a piece of the action? Carmela. Perfect.
I'll take a first bite at that apple, because I think Chet really did put the critically important question on the table at the end of the last meeting. And I think it's the challenge for us, and that is to sift through and separate the opportunities to work together that are, I'll call them aspirational, maybe. The right thing to do, a good thing to do, we have opportunities to do them. Separating that from the accountability mechanisms, either the metrics that will ultimately be part of another future contract. And I think that certainly the alignment was created in the first phase of the waiver because there were clear metrics, and there was a contract, and there was a regulatory structure under which to control those levers. And I think one of our challenges is going to be to figure out, as we expand beyond just the hospital piece, which of these pieces have metrics and payment incentives and literal accountability with rewards and penalties, and which pieces may stay in the, bad word, but I'll call it the aspirational category. But I think there's something very important in what he said to get those categories clear and aligned and understand and follow the dollar in this to understand ultimately how effective what we may do might be.
And I actually wanted to say something here too. I think aligning the outcomes measures that are being used across the system and to align them around the patient and the patient experience and the good outcomes for the patient. So, for example, one of the things that we did early on with the global model is to add to, we worked on avoidable utilization, and we were picking things that if quality improved, then some utilization would be avoided. But we picked on things that were actually happening in the community, the prevention quality indicators, which are really driven a lot out of the work with the long-term care facilities and the primary care providers, and the primary care providers are being held accountable for those measures in their medical home models. And so if we put the same measures into the hospital model that the primary care physicians are being held accountable for, then we have a lot more opportunity to actually succeed, because both parties are actually trying to do the same thing and to work toward improving the same measures. So I think there's a lot of power in creating accountability measures that are consistent across the delivery system, that are focused on better patient care and better health, that then result in the savings that we're trying to generate. And without that alignment, I think some of the models on a standalone basis don't actually perform too well. I mean, some medical home models where you don't have that alignment with the hospital global budget and the aligned outcomes measure, not all of them perform well. They don't actually achieve what they aspire to do because the other side is not necessarily working in the same direction, not investing all of the energy. So, I mean, I think that's an area that needs to be concentrated on as we move forward, is how can we get the outcomes measures aligned across the system so that people will be working toward a common direction.
Yeah, Eric.
Jack, thank you. Maybe to pick up on a piece that I think is a part of what Donna is saying, and maybe and tie it back to a discomfort I had with the direction perhaps that you were taking us, which was to kind of blue sky this thing. Well, what are our ideas? I think there's a lot of ideas out there. I think there's a lot of tools that are out there, a lot of models that are out there, and it seems to me it's not a real productive use of our time to try to come up with new models, as opposed to what about the models that are out there? How could they be adapted? How could they be adopted? Maybe they're perfectly fine now, and so I'll mention two or a couple of them perhaps. I mean, ACOs. Medicare has embraced ACOs. I don't know if they're going to work long-term or not. I don't know that CMS knows whether they're going to work long-term or not, but there's a lot of interest in them, and there's a lot of organizations in Maryland that have adopted them. And as part of adopting them, you are agreeing to a set of quality metrics where there's a lot of overlap, I think, with what Donna is talking about, but it also brings in the opportunity to have aligned incentives. And not just between hospitals and physicians, but potentially with long-term care facilities and others. And I don't know what the metric is right now in terms of how many health systems or how many Medicare beneficiaries are covered under those arrangements today as we speak in Maryland, but my guess is it's a much bigger number than we might think. And so how can we take advantage of that? On the metrics piece, I think we, at a different meeting some of us were at earlier this week, we touched on the fact that CMS has just published a set of, I'll call it harmonized metrics, working with payers to try to come up with a consistent set of metrics for health plans, physicians, hospitals, and the like, so that we get out of the realm of everybody having their own metrics that we're pushing towards. And again, perhaps that should be a focus that we look at, is to say, could we adopt some of those things that CMS is doing to help to further our own work? And then the last piece I would say is, and it's you touched on it yourself in your remarks earlier, there's no one way to get this done. We hear about the PCMH models, and there's some promise there, ACOs, some promise there. But there's also a body of evidence that suggests that maybe some of them aren't working as well. And one that came up on whatever day it was, Tuesday or Wednesday, that CMS thinks has promise. I don't actually think it has promise, because their own metrics show that it's more expensive, the comprehensive primary care model. I mean, it's because at the end of the day, we will be measured by the total amount we spend per beneficiary. That model actually, for 6 out of the 7 regions that participated in that, it either was more expensive or much more expensive, and that's not, one saved money. That wouldn't work for us in Maryland if we just kind of outright adopted it. There may be characteristics of it, and maybe something that merits further attention. But I think we just have to be cautious in terms of how we proceed. And the last thing I would say is that, and maybe tie it back to the old hockey phrase, you skate to where the puck is going and not where it's been. we have to be careful that whatever tools we're using to identify the people, the population that we need to focus on, that they're not so historically based that we're fixing yesterday's problem as opposed to being anticipatory and predictive as to who's going to be the next group of people who fall into a particularly costly bucket. Again, I think there's a body of evidence that suggests that doing it the old way, and we just take the people who cost us a lot now, it's not going to help us a ton. It's those people who are going to move into that next tier up in terms of the cost curve. It's the predictive modeling that we need to think about how to make it more broadly applicable. And again, for my take, that kind of modeling can be applicable in a variety of settings, ACO or PCMH or whatever. But the key is that you got something, and there was an example, a concrete example that got raised in this meeting earlier this week by one of the primary care physicians who said that, in fact, they had some patients that they would have liked to put into case management under a PCMH model, and the payer really didn't want them to because they didn't fit the high cost bucket. But the practice knew from a predictive sense that they were going to be there very shortly, and that would have been a better use of resources. So just, I think there's a body of evidence that we could take advantage of.
Yeah, a lot of good points there, Eric. Thank you. Gene.
So I just want
and
to,
then Ben.
really quickly, one issue that I think is really important to us on this whole alignment issue we're all talking about is with regards to the physicians and the SGR fix, which was our Medicare payment, federally MACRA. In MACRA, it requires that all physicians be on APMs, advanced payment models. And one of the things that I think is really important for aligning the entire physician community, anybody who takes Medicare, is getting that to align with whatever we do here on this. And we should put that in there repeatedly, because while the AMA kind of saying, don't worry, we'll get it delayed like we did SGR, I'm not clear that that's realistic. And even if not, there will be people who say, hey, you know what, this is another reason why I should participate. So I think that's something that we should talk about as part of this whole discussion, and it kind of gets us in the right direction, gets us aligned, it fits in with what we're doing. And you know, if a couple doctors are questionable in gain sharing or participating in the MHA program or whatever else we produce, that might be the thing that throws them over the edge if it qualifies them for the APM, because it could mean the difference in an 18-point spread in their payment, because the negative side could be as much as -9, the positive could be as much as +9. And I'm kind of mixing MACRA and MIPS together on that, but that's the kind of, so I think that's a big issue that for my members it needs to be included in this. Sorry I used so many letters.
No, that's important. Could you remind us what the timetable is for APM?
I think it's 5 years, right? 20, what's the? Yeah, so, but I don't think anything real, do you know, Donna, off the top of your
I
head?
think 2019 is the year when there's supposed to be a 5% differential.
Right.
Or for folks who are in a qualified APM model.
And it's hard to answer it. Well, there's the alignment with regards to MACRA and APMs, and the advanced payment models as part of the MACRA thing, but then there's the whole MIPS thing too, which is all the old meaningful use and PQRS penalties and all that jazz. So you've kind of got both of them, and the point would be that we should figure out how, when we're doing these programs, to align it, because every physician is going to care about that, particularly if they really do it to us instead of delaying it like they did with SGR for 19 years or so. But you know, so it seems to me that that's a way to naturally get doctors to start to listen, because you'll be speaking their language, and particularly on APMs, advanced payment models, it's easy to see where this fits well with that. So, and frankly, a lot of the work we're doing on the data side and with Chris help us with the MIPS stuff too. So it all kind of fits with what's going on, and it just, we should be thinking about that from my side, from my member side, you know, as we go forward.
So thank you. And let me pause a second. We have 3 people on the phone that I know of, do any of them want to jump in now, or don't hesitate when you want to? I know Dean has spoken up, and Bruce is on the phone.
This is Bruce. Just a little comment, because I think this discussion at this point has been pretty much right on point. And but you know, and I'm not even sure who made the remarks, and I apologize for that, not being able to see anything. But the notion of, should we concentrate our efforts on the high-cost patients, or should we use predictive modeling to focus resources on, next year's high-cost patients or the patients most at risk? I think, there's a lot of logic in any system of care, in any allocation of resources, to following a 20/80 rule. You put the most resources where your biggest current or future problems are. But I think, given where we are and given the relative nature of abundance of healthcare resources in at least large parts of Maryland, I think we ought to be talking about what do we do to make sure that everybody gets the most appropriate and highest quality care. And appropriateness is partially a function of your current health status and your risk for near-term deterioration of that status. But I understand the whole notion of hotspotting and of targeting resources and so forth, and there's a lot of good things to be done, but I think we now don't have to get carried away from it. There's enough doctors and enough hospitals in the state of Maryland to set as a goal that everybody in Maryland should get high-quality care. And I think we can get ourselves in trouble if we focus, get too enamored of our fancy, predictive modeling and statistical techniques and decide we're going to put all our resources on the 11 people for whom we get the biggest payoff. So that's not a very systematic comment, but it's just a little bit of a caveat about, as we try to crystallize a lot of the excellent discussion that's going on about, yes, we have to understand who the highest risk and the highest need folks are, but we have to also be very thoughtful about where interventions for them fit in the overall allocation of resources, because everybody who doesn't get good care in the short run is going to be at higher risk in the long run.
Point well taken. I think Ben had a point. Let me bring you in.
So, I listening over the last couple meetings to the idea that, one, we don't want to try too much, yet we want to have flexibility as we move out from a hospital setting. We're going from 47 entities to 200 and 300 comprehensive care facilities and 14,000 physicians. There's going to be, I think, a need to be more flexible, and at the same time recognize that models are not going to work everywhere. I think Eric and I probably disagree a little bit on the CPCI model. Keep in mind that it's probably the most successful advanced primary care model that CMS is running. The others, maybe are not doing quite as well, and there is a lesson there that it is working some places, not all, and I think we're going to have to be selective in terms of pairing communities and geographies with different models as we go forward. How then do you create the overarching sort of alignment? And I think one thing that I picked up from a meeting I actually didn't go to but looked at the slides for, which was the Assistant Secretary for Program Evaluation under the SGR fix convenes a physicians group, and the CMMI people did a presentation showing their successes. I think Eric and Donna saw that presentation. Maryland was in there. They highlighted the savings here. And one thing we need to take advantage of, I think, is this pride of ownership. Hospitals are taking some pride for it now, but the uniting factor of the model needs to be, I think, more globally emphasized, that this is something Maryland corporately owns, not as a government, but the entity of Maryland, the Free State, is doing this, and I don't think that's percolated enough. We've talked a lot about incentives, and economic issues are very important, but the pride of performance, and you see that in physicians oftentimes, that they'll tell you, I'm not driven by incentives, financial incentives, I'm driven by what's the right thing to do. I think we have to leverage this through this model in a way that's just as important as the economic incentives that are going to be key to success.
Good point. You mentioned BPCI. bundled payment. Could you say just a couple more words about that? Sounded like.
Oh, I didn't say C. I said CPCI.
Oh,
CPCI, which is the same program that Eric mentioned a minute ago, and it's in 7 states, and he is correct that only in Oklahoma did it generate savings, but there were some promising results, and if anyone's interested, I'd encourage you to take a look at the Mathematica first-year evaluation of that work that was done. On that last point, I think there are going to be needs to plug into the 29 odd ACOs that are now in place here in Maryland, as well as the expanding group of Medicare Advantage programs that are now taking root here, in addition to the 3 or 4 that have been in place for a long time.
Thank you, David.
So a point of information first, and that has to do with whether the waiver gives you the opportunity to change the way physicians are paid. And if so, whether the MACRA and MIPS rules that are being created for the nation as a whole are necessarily going to be the rules that you're going to want to use here within Maryland. And some of the comments around the table would lead you to believe that MACRA is going to apply just here, just the way it does everywhere else, regardless of the waiver. I'd just be interested to know whether that's true or not. Do we know? Do we have freedom around that?
I was under the impression it was not going to apply the same. That was the problem. That was an issue that we were going to deal with. And having talked to the folks at the AMA, they have like a little asterisk on us, and we're going to be different. So it's a big concern. I think that's an outstanding question.
But it'll also be an opportunity.
Well, I think that's what we're here for, or what I'm here for.
So the second point I wanted to make, just as a point of information, and that is that our predictive analytics for identifying people who are not high cost now but could become high cost are not very well developed. So that if you're thinking about being practical and don't want to do the 4 or 5 years of research that you'd have to do to make sure you've got good analytics from your own data, you may not have the ideal opportunity to use predictive analytics to look at the not yet costly but could be costly group with precision.
Good. Any idea of who's done it sort of well?
We are looking at that. A lot of the tools are proprietary, so they're very hard to estimate or judge. There's a huge. You may have seen that IBM just bought Truven Analytics. This is a big industry developing predictive analytics. So it's very fluid, and I think thankfully so. Hopefully all those big brains and computers will make this a very good area to work in and be very helpful. But I'm just not sure it's ready yet, which is why, as a practical matter, you may be forced to look at to appreciate the fact that the best predictor of costs in next year is costs this year.
Thank you. On your first point, I think Donna was going to. Did you have a comment? What Gene's asterisk comment and allowing Medicare to do? I'm sorry, allowing Maryland to do things somewhat differently than the rest of the states, and in terms of physician payment, I believe it was.
I think the area where Maryland is different is really in the area of BPCI, that we don't have bundled payments here, but we do have ACOs. So there's, in terms of one of the key determinants in the APM is really taking financial responsibility for some of the work that's being done, the financial and outcomes consequences, but financial responsibility. So, so the ACO model is a model that is set up to take financial responsibility. In terms of the BPCI, it's not clear to me how many specialists would ever get an APM exemption looking at a BPCI anyway, because if you have to have half of your revenue from Medicare under an alternative payment model, I can see a handful maybe of orthopedic doctors who specialize in joint replacement qualifying, but the rest of them don't seem to really have a path under BPCI. At least I haven't seen a great big pathway there, but maybe I'm missing something. So I think you could have some unique model for Maryland, that we could develop, but we do have ACOs here.
But the joint replacement is implemented in Maryland, right? Am I wrong about that?
We don't have joint replacement in Maryland.
So the point is that the one example that we have that could theoretically work to fit that, we can't do here. So and I think that will happen repeatedly as we go forward. So I understand your point that we'll find a lot of people who won't be able to get in, and I think there is particularly probably an agenda to reduce specialist pay at the government level. I think that's probably part of what's going on here, and I think we all understand that. Maybe we don't say it, but that's part of what's happening. But it seems to me that for whatever opportunity can be created, that this is something that would excite my members in participating in our goals and align us. So it seems to me that this is an important discussion as part of this going forward for us to be aligned and work together. That's all.
Right, yeah. and so we could do bundled payments in Maryland. We could, but then the issue gets back to what has been said of concentration and focus and where are you going to put your efforts. And so I think the other models of how do you make it work with the global budgets, and some of we've already started working on some pay for outcomes and gain sharing, and can we develop a model around that will work, or around ACOs, or around primary care?
I mean, this might be too simple, or maybe I'm oversimplifying things, but what if we were to just simply ask CMS to say that any doctor who's participating in the MHA gain sharing program, once it's approved, has met their APM requirement? I mean, that seems like not a heavy, if they would say yes to that, it kind of solves the problem, and then that would really encourage doctors who maybe otherwise wouldn't be encouraged to participate in it. So that was the kind of thing I was thinking about. I wasn't, I just think we should look at what we're doing and see if we can meet multiple requirements at the same time.
Right.
So that might meet Eric's point, I think, to some extent, of build on what you're doing rather than starting over.
I actually think we're agreeing at the risk of agreeing with MedStar.
Yes.
Yeah.
Florida.
As a private practicing internist and in the community for a long time, I have my only experience with BPCI, the CP, all these acronyms I'm having difficulty with. But my only experience with them is, in terms of payment models, is PCMH. And I'm not sure whether or not the CPCI is part of that PCMH experience or not. But the point that I wanted to make mostly was that I have found that in the program that I'm working with Care First, has been really instrumental in getting the group of doctors that are in my panel to really work on trying to increase their quality, increase their outreach to the patients, and then to make sure that we bring them into alliance or help them with the healthcare system so that they're not being so expensive and so costly to the system, and improving the quality of the care that we're providing to them. And so I was hoping that might be also one of the models that we're looking at, because that is the one experience that I know I have, and that, as you mentioned, Jack, that the fact that we need to have data. When you give us data, then we know what we're doing in terms of referrals that we're making and how costly that might be for the patient, and how much the patients are following up in terms of getting their pharmaceutical or their medications from the pharmacies. And then also, as also stated too by Ben, was the fact that we do take pride in being able to provide quality care. It's not about the incentives. It's, you show me data that says that I'm really improving quality-wise, I'm going to do a whole lot better than being in the dark and not knowing whether or not I'm doing well or how I'm doing, and that the people that I might be referring to, whether they're at the hospital or at an independent facility, are more costly to the system than having them in a private practice office setting. So the feedback is very important, and I think that that PCMH model is one that we already know is going on right now with Care First. Then we need to bring that in terms of trying to address the issues that we're sitting here for today.
That's an important point, Melarda. Thank you. Over the years, I keep hearing that when a physician is not confronted in a confrontational way, but sits down with another physician leader, medical director or something, and sort of saying, here's where the best are, here's the mean, and here's where you are, and here are 3 tools to get you up there. They react very well to that, rather than out of pride. And gee, I didn't realize, an example that was given to me at one major hospital, Beth Israel Deaconess a few years ago, is that, there was a big variance in time in the OR, time that the patient was on heart-lung, or, the machine was taking over for the heart. David's a physician. Some of you are physicians. I apologize, I'm not explaining. I do remember it was 2 to 1. And I remember somebody saying when the medical director, because often the ones up here were older physicians, and the ones doing better were younger physicians, and when they were brought that information, they said, I had no idea, but I'm going to try to change, and just what you're saying. Yeah, Vinny.
Yeah, thank you very much, Jack. I just wanted to support what I think it was Bruce said on the phone about we need to focus attention on the people at the top of the pyramid. We also are the sickest people. We shouldn't put all our time, energy, resources there. We should do whatever we can to keep people at the bottom of the pyramid there, to keep people healthy. Preventive health, of course, as well as public health measures, keeping people from smoking, reducing obesity, reducing drug and alcohol abuse. We will get so much better overall population health that way, and keep costs down if we focus at least some of our energies on that, keeping people healthy and down at the bottom of that pyramid.
Thank you. I think, Ben, you had... Oh, okay. Yes.
I just want to agree with Dr. Edwards. I'm sitting listening to all these acronyms and abbreviations and initials, and my head's spinning. I don't know what most of them mean, but I can tell you, as a primary care doctor in the trenches, the things that we care about is identifying the patients who are high-cost patients, and we like to know who they are, because to us, it's not so much high cost, but those are the people who are not doing well. And so we need to identify them, and then, and I know this has been said in 100 different ways in here already, but we also have to have an incentive to want to do something about it. And part of the incentive is we want to do a better job, but the financial incentive goes a long way to making primary care doctors listen. And what Dr. Edwards said about Care First and their PCMH program, it was a big eye-opener for the people, for myself and the other doctors that I work with in our practice, to finally be able to get some information and to see who these people are and to have some tools to make it better. Because prior to that, we were just operating in the dark. So,
do you think that, this is a question for either you or Melarda, since my understanding of that model is that a big part of it is showing physicians like you how the specialists are doing in a comparative sense?
I was going to bring that up.
And cost, is that affecting your?
It is, and that's
your referrals.
When this program was first introduced to us, I think they kind of moved us into it slowly, but we've been working with Care First for a while, and now Care First is giving us information about who the high-cost specialists are, and some other quality issues, and that's taken a little bit of time to figure out how you're going to deal with that, because I've been practicing for 34 years, and I have relationships with some high-cost specialists, and changing the way I do that is challenging. But prior to getting that information, like I said, we were operating in the dark, and I'm willing to change. And I think most primary care doctors are willing to change, but we need to have the information.
On that aspect as far as the specialists go, one of the things that I said immediately once I saw where they ranked all of the different specialists, as Tom has also mentioned, the fact that we have good relationships with some of them, and you don't want to stop referring your patients to them. My first question was, are you sharing this information with the specialists? Do they know that they're high cost and in the blue or in the green or with the yellow or in the red? And my thought is that if we're going to do this and really move forward with that sort of model going forward for the waiver, then we really need to also open up and share that information with our specialists, because then they need to also be able to make changes, perhaps if there's possible, in terms of their cost or whatever the reason for them being in the red as opposed to the green. And that kind of feedback has to be done in terms of sharing the data.
There's no specialists here, so let me just tell you what I believe they would say if they were here, because I think it's important. First of all, from a fairness point of view, the care first thing, and I've talked to Chet about this, God bless him, it doesn't give any quality data at all, and you said that a couple of times. All it does is color code these folks. And the other issue is, and I'll try to pick hospitals who aren't in the room, when you're color coding a doctor, if you color code a surgeon from GBMC and you color code a surgeon from Johns Hopkins, the color code for the Hopkins doctor is going to be much worse than the one from the GBMC. And it has to do with the way the facility fee rates are charged. And that's being calculated in there. So you have to take into consideration the fact that Hopkins is also doing GME and all this uncompensated care and all this other stuff. And maybe the GBMC doctor is a better doctor, maybe they're not, maybe they're totally equal, but we've decided to have a system that's set up like that. So there's a lot of stuff that kind of gets cooked in there that gets ignored if we're not careful, and that's a concern that I have. Another thing that I've seen, and this is one, and this is outside of the area where either one of them practice, in Wicomico County there's really 2 cardiology practices for all intents and purposes. I've seen the color code that they give out for cardiologists. It's almost humorous, because the way the color code is done, the guys who are like retire-ish or kind of almost retired or not doing as many procedures, they get greens. But the ones who are doing most of the work for you, and actually I think they're all good doctors, yeah, and they're getting reds, but they're the doctors that you really want to have doing the work for you, They're not, you don't want the guy who's on the really only just doing a couple stress tests and hanging out in the office because he's, and plays golf on Wednesday. That's not the guy that you want to see. So I'm concerned that the focus at times when it's done just by insurance companies is only on the money and not on the quality, and there's no measure at all for the other factors in the system. Because if we use that system that they're using in PCMH, Bob's always going to lose. He's always going to lose. His guys are always going to be red because they're always going to be expensive because he's paying for a teaching institute and a whole lot of uncompensated care that another hospital might have to pay for.
And probably taking the most
so
complex
that's I just think we need to be cautious on that stuff.
Point well taken. Speaking of that, this is the time in the conversation when I pause for a second and say, is there anyone who hasn't had a chance to chime in who would like to? I don't want to put anybody on the spot, but this has been an interesting time. Joe.
I'd like to take the conversation in just a little different direction just for a minute.
Yeah.
But within the theme of accountability, and that is at some point, at some level, we're in the early stages of this work. A lot of the work we do for individual patients is empowerment and education and whatnot. But there is also this this issue of health risk behaviors unchecked and unmanaged, and at what point and at what level do we begin to acknowledge that in the financial model as well? And I was struck sitting here listening to a lot of folks that work in healthcare and work in public policy. In other states where cost of care and quality of care have been taken on, employers many times are significant players in those conversations because individuals value their jobs. And so when employers begin to set expectations about health behaviors, people respond differently
than when even their physician sets expectations of health behaviors. And I just hope we at least capture the idea that the employer-employee relationship is a leverage point in helping people form better habits over time. And I know as the largest employer in Washington County, we've started down that road, albeit very cautiously, and more with empowerment and awareness at this point, but with a very real expectation that we're going to differentiate copays and differentiate premium sharing over time based upon choices people consistently make over time. And the most
this is Bruce Vodek. I want to object very strongly to that whole line of policy. I think there's
Bruce,
a lot of
let
things.
let him just finish his thought, and then I'll bring you in.
No, I thought he had. I apologize.
Yeah, that's all right. Go ahead, Joe. Finish it.
Well, no, it doesn't change the whole field, because I mean ultimately, in the end, the patient's got to be a partner in all of this as well. And maybe my approach is not the right approach. Maybe it's more hand-holding or whatever. But in the end, at some point, at some level, it's those behaviors that drive the downstream cost. And somewhere, somehow, it's got to matter. And ultimately, in Maryland today, or at least in my market today, 75% of the patients coming through the door are paid for by either Medicare or Medicaid. But that means 25% are paid for by the employers in our market. And so I think the employers have a stake in the outcomes as well.
Okay, Bruce. Sorry, I didn't mean to
just
cut you off, but Joe wasn't quite done. Go ahead.
Yeah, I apologize. I didn't realize that. I just want to say a couple of things. One is, at the broader public policy level, there has been such a disempowerment of the average working person relative to his or her employer in this country over the last 20 or 25 years. To add further to it and to legitimate the employer's interference with decisions people make about their personal health is really coercive, and I think it's a very dangerous, slippery slope. I think there are all kinds of voluntary things employers can and should do to encourage better health on the part of their employees. They should start by following the law on occupational health and toxic exposures in the workplace. That would help a lot right at the outset. And there are other positive things they can do as well. But the notion that we should use employment as a club to change health behaviors, A, is likely to be counterproductive, and B, is just, I think, intrinsically objectionable.
Yeah, I think Joe was talking more about carrots and helping things than clubs, but it's a fair disagreement.
Once you start talking about varying copays based on compliance with expectations about health performance, you're talking about coercion.
Okay, we'll leave it at that. Thanks to both. Lenny.
So just on the patient end of things, and then one other thought, but under the principles for the patient, it's the engaged patient, which I wholly agree with, obviously. But the statement, responsibility for prevention and self-management, I think there's got to be more nuance there, because the patient doesn't necessarily come in with that knowledge and hence can't necessarily be responsible from the outset, but needs the support of the physician. So I actually think maybe looking at physician engagement comment as a part of this would be helpful, because that's really a two-way street. But to go back to...
Remind me which chart you're looking at.
Oh, I was looking at the slide deck, page 11.
Okay.
With a set of principles.
Okay.
And I had also made a note to myself about equitable access to care under the population principles. There was supporting the social needs and addressing the social determinants of health. I think to get to an earlier point made, if there was a positive statement about a principle being health equity, so that we are in fact sort of baking into this the equitable access to high quality, comprehensive, affordable care, that would be a positive approach.
Thank you. That's helpful. I want to go back to a point, and we're going to start shifting in a couple minutes to, it'll be my job to try to get some consensus around some key guiding principles, to the extent we can get some consensus as HSCRC goes forward in implementation. Really pay attention to these principles. I just want to pause for 1 second and go back to, because there was a good bit of discussion about ACOs, and get a couple thoughts from you about that. You know, I kind of look at ACO development, and many, if not all of you, know more about how far along it is in this state than I do. But there's a continuum in Vermont. You know, we're working with Vermont that's actually trying to do a version of an all-payer system. Very impressed with what Maryland is doing. But I think they have, it's a small state, they have 3 ACOs, and it's my understanding they're all full risk. A lot of quality metrics to meet, but they're more or less capitated. That's probably the wrong word, but it's double-sided risk. Does anybody have a sense, without getting into the weeds, of these 29 or so ACOs that were mentioned? Are some leaders, you don't have to mention names, you know, is there some excitement about what they're doing at this stage? Is this something that we should be trying to foster more development of into stronger entities, or not? Just a question. Any of you have been tracking this?
I'm glad that you bring that up, and that's because from my own personal experience, when we first started talking about ACOs as a single or 2 physician practice, I was excited about the possibility of what could happen. But then as we got the information about ACOs, we were told as individual physicians, you can only be part of one. And then everyone in private practice was worried about, well, who am I going to get together with, and will it be putting me at risk and so forth. And as a result, many of my colleagues just didn't get into it. And so I'm not part of one of those 29 ACOs, and I don't have the feel for that. But my point that I wanted to make is that many people who thought that they might want to get involved with that didn't, because they were told they could only be part of one. And sometimes you want to kind of try a couple of them, see which one's going to work for you. Well, then sometimes you just have to say, I'm not going to do it at all.
They wanted you to sign an exclusive arrangement. Donna.
A number of the ACOs, there are a number of them are focused on employed physicians, and so so that brings a particular approach. I think one of the things that Eric said is to build on what you're already doing. And so one of the things that we're already doing are global budgets and some regional partnerships and some things on a geographic basis. And so one of the things that we may be able to build on in Maryland that is to build around that unique global model into some geographies. And so that wouldn't necessarily create an exclusive situation where you would only have to work with one, because it's more of a geographic approach. So I think there's certainly some opportunity to take what we're already building and to build around that unique thing that we've started in Maryland. And that's not to say don't work with ACOs, because we should test multiple things in the state, but I think we do have that opportunity here, and it is kind of what it builds on what the Hospital Association has been working on with the gain sharing is now getting a new name called internal cost savings. So that's the new CMS term. So we're going to have to rebrand that. But and then also with working with the pay for outcomes, which is driven around the primary care and the global budget, and more into a geographic type of a thought process. So or something that is revolving more around the global model that works with it. That could organize outside of it, but work with it, seems to be an opportunity to pursue.
It seems on that point that we've talked about what I would call techniques here, whether that's care management or health education. We've talked about data as a critical piece, and we've talked about reimbursement methods as a piece. At the end of the day, the acid test is change in per capita cost. And so I think as we struggle with how many of these things we could do, the gold standard is the closer it gets to influencing positively per capita cost and change in per capita cost, the better off we are. Obviously, there's several quality riders, which I think you're going to have to address to do per capita cost anyway. But I really do think that whatever the system we head to, we want to try to make the path between there as clean and as simple as possible, because I think that leaves you with fewer interventions, fewer regulations, less complexity. If we could all leave the field and people would somehow do whatever it took to make that number work, we should just leave the field. I mean, that would be a success however it happens. But I think coming up with okay, so start with 0. What do you do first, second, third? I would say the thing that has the absolute most impact, and it has to get you toward attribution. There really is, in my mind, somehow we've got to get people lined up with some aspects of care delivery, or we won't be able, because you want to be able to step back from it and say, if they do what they say within these incentives, we as a whole state will come out the other side well too. Now we'll share good ideas and help them. But at the end of the day, if you don't have that, I think it's going to be very hard to know where to put your resources, and I think very hard to know whether you're going to be successful or not. And so the tendency when you don't know is to overdo it in terms of how tightly you set the parameters and how many things you try to do. So I think spending some time on getting the most direct and fastest and closest connection between whatever it is we're doing and influencing per capita cost is worth some groundwork, because I think it will help us create a ruler to do a lot of the other pieces.
That's very helpful. I mean, so do you see attribution leading to a process of delineating the population that a provider is accountable for, or
Yeah, I think it's going to end up being more like ACO, and that you're not going to be able to tell everybody in the state you got to go there. That ain't going to work.
Yeah.
But there's got to be some aspect of where there's a lot of connectivity between the person and some delivery system, because we're going to be talking about hospitals that are controlled, other parts of the health delivery system that are not in nearly the same way, and somehow working together to get you somewhere. It's not a simple. I mean, it makes the top of your head come off. Any thoughts, Bob? Fine.
Yeah, I tend to agree with Kevin that and something to watch here is the history of this waiver, which is that it's an all-payer system, but the Medicare program controls to a great degree. If they're not satisfied for their payer where we're going and the results we're delivering, game over. So I think one of the things we'll need to reconcile is what are the expectations of CMS going forward, and can we? I mean, right now we're already bumping up with the first phase of the waiver. I believe, Donna, we're bumping up against issues with how fast Medicare per capita costs are growing on the hospital side versus all payer. And in the history of this waiver is Medicare many times controlled. What was going on with the Medicare payer was controlling what the rate commission could or could not do for all payers. And I think we've got to reconcile that.
very much up front is where we go. Can we afford to focus across all payers early on? To Kevin's point, or do we really need to focus down on what we can do with Medicare and how fast we can do it and where we can create the most impact in the short run? So I think we're on the clock, and I think it's going to be hard. We're going to have to keep it simple, keep it focused, and I'd like to know is it ultimately going to be Medicare that's going to call the tune here in the short run?
Jack, I would support what both Kevin and Bob have just said, and I'd add another dimension to what Bob said in terms of it's Medicare who's going to be looking at us and evaluating whether we've succeeded, but it's also Medicare that's the least managed of any of the populations in the state. The Medicaid population is largely enrolled in MCOs, all of whom have got significant financial interest in doing the right thing and keeping the costs down and being measured on quality and so forth. The commercial population, I think, in similar fashion. United's got its model, CareFirst has got its model, Aetna's got its model. Those populations are managed. They are focused on quality and cost and utilization and so forth. It's Medicare where the population is less managed. If we're going to bring down utilization, that's, I think, where the focus needs to be. And I want to tie back, because I think I was misunderstood in what I was saying in terms of stratification models. Certainly, I agree with David that the best predictor is what has happened historically in terms of your cost, and certainly the better models take that into account as well as other factors. My point is simply, we don't have the luxury of boiling the ocean. We need to figure out, as Bob just articulated, where we need to focus our efforts. And back to Bruce's point, I think, Bruce, maybe you misunderstood me as well. I'm not advocating that we're not providing health care to everybody. I agree. We have enough resources in the state to provide good health care for everybody. The question is, what can we do to support those populations that are the most costly and to ensure that they don't bump up into a higher cost situation and that we're dealing with their needs and achieving better outcomes in the process? And to me, that is where predictive modeling, however it's based and however sophisticated it is, comes into play. Is it's about focusing our resources in terms of adding that layer of management, providing information to primary care physicians. I mean, I think Dr. Edwards talked about getting the data from CareFirst for the first time. It was not just about how expensive the specialists are. It was also about which patients did she and her practice need to focus on in terms of making sure that they got in and so forth. That's what my point was, and I think that's where we have to focus.
Okay, thank you all. The last three comments, Kevin, Bob, and Eric, form the segue to the next section of our discussion, which is to set some key guiding principles and priorities of what you all think should be focused on in the work going forward. There are many ideas that have come up just today and many last time. And building off what Kevin said and Bob, what do some of you think, first, second, third? I'm kind of thinking that way because I agree we want to improve health across the state. We also are in a state that 8 or 9% of the Medicare population is in an MA plan. I think the national average is 30%. I may be off by 1 percentage point, but it's pretty close. This is a low penetration MA state. And and the point that was made by Bob, I think, Medicare is a key dance partner here. And, they're coming out and want their money, They want to see that they're, not costing themselves money by allowing Maryland to allow Maryland to pay in a way that's different than the way Medicare pays in the other 49 states. So with those things in mind, what forms a set of strategic plans, guiding principles? How can we write that down in a way that would be not that the other things are unimportant, but they may be phase 2 or, second order. Not giving short shrift to the duals, which are right behind, and and the broader Medicaid population and the commercially insured population, and not to mention there's still some uninsured, despite Maryland being an expansion state and having high eligibility standards. So help me out in terms of setting some guidance along that you want to give to Donna and her commissioners about if you have some resources to spend, both money and work, hard work. Where would you place your first bets or your biggest bets?
Right.
So Jack, this is
first Joe, and then I'll
Bruce again. But can I ask sort of a background question for this conversation in the context of what we've just been talking about? It would be, as we try to determine priorities or places where the next generation of the Commission's work should focus. I mean, everybody's got, and they're mostly good things, everybody's got their own sense of what ought to be a priority and whatnot, and what subpopulation ought to be a priority and whatnot. And maybe all the Maryland folks know this, but it would be really helpful to me if the staff, and maybe it's already been done, I just haven't seen it, but if the staff could provide us with some data, now that we're moving from looking at hospital costs per capita to total Medicare cost per beneficiary, to look at how Maryland performs on cost per beneficiary broken down by the categories of Medicare payment and service. So I think we've spent 30 years talking about Medicare cost per case and now cost per beneficiary for inpatient hospital care, but in terms of where the next focus ought to be, if the direction is constrained by the 800-pound gorilla that controls the waiver, then if we're low on primary care docs and high on specialists, we ought to focus on getting more people into primary care case management. If we're high on primary care and low on specialists, then maybe our problem is post-acute. I don't know what the baseline is on which we're trying to meet these twin goals of improving the quality and availability of care and giving something back to CMS in terms of our impact on Medicare costs. So I don't know how far we can go in formulating a strategy until we have a much clearer sense, or I'm using the royal we, I apologize. I personally, I've heard a whole lot of good ideas in a whole lot of different forms, but given the very helpful reminder that we're ultimately constrained by CMS's agenda, it would be really good to know, in order to evaluate sort of competing priorities, where the apparent problem spots are in existing patterns of Medicare use and spending in Maryland, and where we're already in good faith. And I don't know that, and I think it would be very helpful if we could have that information before the next meeting or something.
Well, we have some information. We certainly have information at certain levels on Medicare spending in comparisons to national averages and comparisons within the state. And we actually just recently put a database up on CRISP to have people start looking at the data and be able to look at it in a lot of different ways. And so we can definitely provide some of that information. I think at a high level, certainly the hospital stands out as the area where there's still, if we look at any benchmarks, there's still a lot of medical utilization in hospitals that is potentially avoidable with through collaboration with long-term care facilities and primary care and other aspects of the delivery system. So I think that is continues from, at least from the staff's point of view, to be a very high priority. We have statistics that we have calculated and shared with the hospitals on potentially avoidable utilization, and there could be more, but at least we have shared some of that information. So we think there's a lot of work there with the Medicare population. I think the second area that the staff has been focused on, and also DHMH has been focused on, the dual eligible population. Dual eligible population is the only Medicaid population, large Medicaid population, that is not in a managed care approach. So we've been focused on post-acute as a potential area for that has been shown nationally to have a lot of variation in terms of usage and some opportunity. But we think in Maryland it's different because in other parts of the country, people are not so much interested in the inbound side. They're what's coming in from long-term care. They're mostly interested in the post-acute, in the bundled payment program. But we really need a much better partnership with our long-term and post-acute facilities in Maryland. We need to think of them as partners, not downstream, because it's really, you know, the literature says that we can get 70% of inbound admissions not happening if we really co-invest in some good care delivery interventions with the long-term care facilities. And so we know that there's quite a bit of inbound admissions to hospitals from long-term care facilities. So the staff and the industry really, MHA really has led a lot of efforts for the last 4 years of focusing on partnering with the long-term care industry and post-acute industry. So that, you know, we think that there's a lot of opportunity to work together in those two areas, and also really of making sure that we bring primary care really into the picture to make sure that the Medicare patients and other patients who have high needs are actually getting served better. So you said you're interested in cost because you want to serve the patients better. And if you serve them better, they're not going to end up in the hospital as frequently. So I think it's really, to me, it's about trying to serve the patients better so they don't end up where hospitals really don't want to be. And so I think, you know, that's at least been a lot of the conversation that has been, you know, going around. So we do have the cost data. And the cost, I'm sure there are other areas of variation, but those are areas that have large variation and seem like a sufficiently large task to take on in the short term, in the midterm.
I would just add, and I wouldn't argue with any of that or question the importance of those directions. The only thing I would just point out is that if you look at interstate variations in per capita Medicare spending, the biggest source of variation is on post-acute services.
And we're actually, we're actually, our total cost for post-acute care services is under the national average, but our nursing home cost is actually at or above the national average. Our home health and our hospice are below the national average. So we'll definitely provide that back to you, but our sense from looking at the data is to focus on the you know, on the long-term care SNF, but really post-acute generally, and the hospital side, and there's a special relationship here in Maryland because of the global budgets that doesn't exist in other places where we're just looking at things like BPCI, because we are interested in, the hospitals are more interested in Maryland in avoiding inbound admissions that can happen, that where we can stabilize patients and do, you know, really make them, give them better care by not necessarily always moving them around. And I think we have a great opportunity to do that with the model we have here.
Jack, jumping in now. It's actually really appropriate that I'm jumping in now, so it works out much better. So it works really great. No, Donna, I appreciate what you said. You know, Izzy and Carmela and I have been working together for a number of years on this front. Just a couple of observations. So you're right that the Medicare spend, post-acute, long-term care in total is lower than the national average, and the SNF spend is at or slightly above the national average. I said at the meeting that one of the things that excites me about being in this group is that we have tremendous capacity and expertise in Maryland. I mean, you see it around this table. And that's one of the reasons that in the case of SNFs, you see that utilization at or just above national averages, because we had a rate system that was designed around the same time, a little after actually the first waiver in the early 80s, that encouraged high acuity patients ahead of the rest of the country, really, to be cared for in skilled nursing and rehab centers. So what's normal in the country in terms of high acuity care started in Maryland 15, 20 years ahead of the rest of the country. So if you go into Izzy and my centers, they're doing really everything except emergency department and surgery. You know, they're doing intravenous care, they're doing vent care, they have step-down units and all of that, and that's part of the reason. And that's part of the reason that this is an exciting conversation, because if we can reduce the number of avoidable admissions into SNFs and then build on that no upstream, no downstream partnership that Dana spoke of in terms of the hospitals, now we're in the sweet spot, right? So now back to what I was going to say if I had spoken earlier. That's just sort of wrapping up the points. Driving home some principles that are front of mind. You know, I couldn't agree more with Peggy that, and I just got to remind everybody again, it's just taking the time to understand the data is so important, because it's not just about rehospitalization as an example. It's about the variance on rehospitalization and partnership, let's say on a hip versus a stroke, you know, versus some other high acuity, high touch patient. So that's the thing, is taking the time to really, it should be a guiding principle, taking the time to really understand the data. And then secondly, to honor our clinical practitioners and to be driven that everything has to be driven clinically. It's clinical first, because my suspicion is that if we're driven clinically first, the money will work out. So to be clinically driven should be a guiding principle. And then Donna actually hit on the principle that I was going to share as my third principle, which is there is no upstream, there is no downstream. We aren't vendors anymore, or suppliers anymore. We're partners. The only way it works is if we look at each other as partners. So I would say those three guiding principles: honor and take the time to understand the data, talking deep data, be clinically driven, and recognize that this is a partnership and not a vendor-supplier relationship. We'll just throw those up as guiding principles.
That is very helpful. Not vendors anymore, but partners. I like that. You got me. This is what I wanted to get, and then you even said 1, 2, 3. So Peggy, then Vinny.
One is a comment, the other is a question. The first is, I find the principles to be focused on patients and communities at large. So I'm looking also for strengthening the language around the provider community with respect to access, efficiency, equity, solvency, stability, and going back to the predictability question, hoping that those that terminology and language will be embedded in the principles going forward. I do want to sidestep, though, for a moment, because I know the focus...
Let me see if I got that. I'm sorry to interrupt, but when people are helping me, I like to make sure I understand how they're helping me. Access, efficiency, equity, solvency, and stability.
And some level of predictability.
And predictability.
My observation, and I think we've heard this echoed from a variety of folks, is that form follows function, and so my orientation is a systems orientation in my training, and what we want to avoid is, as we evolve, the Mr. Potato Head approach to the project management focus, if you will, and we have a broad system. Now we're at a level with a programmatic, what are the key economic drivers, what are the outcome measures, and a very strong system orientation, I think, to our future. And I think that's a task force that perhaps we can assist with in a small number of folks, but I really think we need a broad Maryland plan that now, after 2.5 years in this industry and working, where are the key levers? We've got our mission, our vision, our principles, but now we're at a point where are the key levers, where are the outcome measures, and I know it's in Donna's mind, a very bright mind, and there's components of it out there in terms of the reports that we receive, but collectively now looking at that as a holistic approach to the management, to the per capita discussion with some of these primary principles. My comment, then that ends on my principles. I'm going back and putting David on the spot, Jack, because I saw that you had your hand raised earlier, and when someone from the Commonwealth wants to contribute to this discussion, I'm always interested. So it's okay.
I'm very small.
But I think the Commonwealth has a lot to, we have a lot to learn from.
Yeah.
So I'm just curious about what the contribution was.
Thank you. Sorry, David.
It was context specific, but it had to do with choosing what you do. And I think having a set of principles for choice is, as you've laid out, very important, and knowing what the parameters are, knowing what your resources are, and so on. There's one other choice criterion, which I think, given all the many things you have to choose among in terms of potential ways of going at this very big and important problem, is time. You've got a waiver timeline, and you've got to produce results in a certain time frame. There are some things you can do that Kevin was talking about that are very clearly related to a cost saving or a quality improvement, but some take longer than others. If you've got to produce results in 2, 3, 4, 5 years, you're going to have to do things to produce results in that time frame. One of the facts about prevention, as attractive as it is that often the payoff for prevention is many years out. That's one of the reasons why it's, if you're on the spot for short-term results, investing in behavior change, wonderful to do for population health, but may not produce the results you want in the first phase. So that was the point I wanted. What I hear you doing is narrowing down in terms of the criteria you're applying to the interventions, to choose among the interventions, and I think that's, with all due humility, coming from the outside, sounds like a very constructive way to move forward. The other thing I'd like to say, just how ambitious and exciting what you're trying to do is, just as someone who comes at this from a national perspective. What you're doing is trying to do is unprecedented, and to reform a health system for a whole state, fortunately a smaller state, to try to get the savings you're trying to get on a per capita basis. And it may all be obvious to you, but I didn't appreciate it till I got into this a little bit more. So you have a lot to teach. You will learn an enormous amount about what can be done, and somebody should be keeping track of that as well.
Thank you. Thank you for the ideas, and also, I can tell you, it happened 2 days ago. Vermont is a state that's trying to learn from what this state is doing. There are probably others. Vermont's a little more systematic about it. Oregon's a leader. You know the leading states, David. And so sometimes we get so enmeshed in the BPCI versus the CCPI, and we forget that. So it's nice to know. And I think CMMI gets it. There are a lot of people who have trouble getting a meeting with CMMI because they're tweaking. So I have a question for Peggy and then Vinny. And by the way, as a general rule, if any of you see me missing somebody's hand being up, thank you, Peggy, poke me, give me a note, because I don't like to do that. But as you see, I also scribble notes and try to get jab me, whatever. I just want to come back to something you said because it was so important to me. Everything you said was good. It seemed to me, but tell me if I have this right or not quite right or wrong, that you said maybe start with understanding the key cost drivers, the key forces that are bearing down on us, and that will help you then figure out the key levers to pull. Did I get that? Or
that's a component of what I was speaking to. I'm speaking more from a programmatic perspective and as a statewide initiative. And how do we now create the full framework? We've had 2.5 years of history and data and certain key programs that have been embedded in the process, and we will have the future HSCRC grants. But to look at it programmatically from a very broad system perspective now. We have MHA who's providing dashboards and a host of information, and all of that is part of the makeup of the program. But to take our mission, vision, our principles, and now fully say to begin to explain this is the program in terms of working with CMMI and the next set of expectations. It's a general engineering principle of form follows function, and the way that I've best explained it usually is to avoid the Mr. Potato Head, because with the pace of change, there's a natural inclination to insert this program and insert this program and have unintended consequences and then clean it up afterwards. So I think we're at a level of maturity in the cycle of innovation and development that we can begin now to look at it as a master plan and really take that systems approach around that and have that as a template that we're working from. It's the agreement that feeds into that, obviously, 1.0 agreement and 1.5 or total cost of care agreement. There's all the elements that feed into that give it there's the skeleton and then there's the organs, if you will.
That's how. Wasn't there a Mrs. Potato Head?
As long as you get the eyes and the lips first, the hat, it's okay.
Yeah, let's try ears first.
Memory lane.
Let's learn. Yeah. Thanks.
Touche.
That's helpful. That's very helpful. Vinny, yeah.
Thank you, Jack. David is, of course, right that prevention in public health gives you long-term benefits more than short-term. But I still strongly believe and hope that if we write out a guiding principles, one of the guiding principles should be that a goal of health system transformation in Maryland should be to encourage preventive care and improve public health. From reducing smoking, obesity, drug and alcohol abuse, improving mental health, any way we can improve public health keeps people healthy and out of those categories that drive up costs and keep people unhealthy. And so I really urge that be one of our guiding principles. And I'm going to talk a little later about how the Faith Community Health Network can help achieve those goals. But for right now, I just urge that be one of our primary guiding principles.
Good point. I frequently quote my colleague Jonathan Fielding from LA and public health, UCLA, but for a good while the LA County Public Health Director, who says, I don't think he invented this, but he reminds people of it all the time, that a person's zip code may be more important to their health than their genetic code. And that's consistent. It's the built environment, it's the behavior, it's the air quality, and it's the dilapidated housing, and it's the lack of transportation. That yes, these do not have quick payoffs, but if we only do the quick payoffs and don't also address the forces driving people into this health system, we'll never get ahead of the game in the long run. We might get ahead in the short run, So I don't think these are mutually exclusive.
No.
Point well taken. Lenny.
Well, I would just say the two words health equity is what you're talking about.
Okay. I mean, yeah. I mean, it certainly is. There are a lot of people who, you know, if their car breaks down, they don't get to work and their pay is docked. And you know, if our car breaks down, we call AAA and then call the office and say, yeah, I'm going to be a couple hours late. You know, and that kind of thinking is true of health too. We forget about the people that can't get a bus to get to a doctor, and so they don't go. You know. Okay, Carmela. We're making good progress.
And as I'm listening, I wonder if we're trying to stuff a lot into one bag, and I'm wondering if there's more than one bag here. That is, I'm hearing not only principles for the care delivery system we're trying to build. Peggy, those were some of the words you were using around access and efficiency and equity and stability and predictability. I'm also hearing principles for the working relationship moving ahead. And Joe, those were some of yours, clinically driven, data-driven, you know, partnership-driven. And then you also asked about a strategic plan, which is maybe it's not principles, but it's this notion Bruce has mentioned. We need to look at the baseline data, but then it's the identification of the next steps, the focus that we need to have. And I'm just wondering if we need to think about this not just as one big bucket of principles, but separate buckets that may create a roadmap for where we're heading.
Yes, thank you. That's a very welcome clarification, and I think I was putting too many disparate things in one. And so there are maybe 3 tracks, but certainly I'm open to suggestions about the identification of next steps. Not all the weeds of next steps. We have very smart and dedicated staff that work at HSCRC and DHMH to work a lot of that out. But at a little broader level, the next steps and priorities. Willarda, and then I will come back to you.
Oh,
Thank you. Oh, thank you. Responding to my request.
You know, listening to Bob's comments and others about focusing on Medicare, because ultimately that's the hurdle that we're working on, and thinking about the change in the Medicaid story post MCO. And I think most people would acknowledge that moving the bulk of that population, nearly 90% of that population, to the MCOs resulted in a different management structure and over time perhaps a more efficient delivery of care to them. And we've got different models emerging, maybe only a couple of models emerging in the state around the Medicare population. One is you know, I was struck by the 9% versus 30% Medicare Advantage number, and feels like that market's starting to bubble at least. And then we do have some ACOs around that have looked at data and at least beginning to understand where they're at variance with averages. Somehow in all of that, I think, lies the strategic plan that we started with. We need the data, and maybe the strategic plan begins with we need the data. We have 3 ACOs in Western Maryland, and we have received 2 years of data in one of the 3, and then 1 year of data in the other 2. And you know, the learning so far has been the cost aberrations vary from community to community, depending on everything from availability of services to just traditional referral patterns. But if we knew those variations around the state, and we knew who the players are that are emerging around trying to manage the Medicare population, you know, I guess it's an observation that the management interventions may lie therein. I mean, we keep coming back to trying to build a lot of management interventions into the delivery system,
and I think a lot of them are helpful. And then I think we're being called into some areas where over time we may not be very effective at that. And so I think it's something to think a lot about, is the idea of the ACOs are in place. And I think if you talk to people that are experimenting with the ACOs in our state, they're almost all in the Medicare Shared Savings Program. And the underlying thought was, we don't know how to manage this population, but here's a relatively low-risk way to learn. And I'm not part of any initiatives around Medicare Advantage plans, but it seems that if you formed a Medicare Advantage plan, you've got a confidence level in your ability to manage care, and so you're after a different risk point and reward point. But with those structures in place, and they're going to bring management to the table in a lot of markets, and it seems that then we're left with figuring out a gap, figuring out how to plug the gap from there. And what you use to do that, I think, is fair discussion and a strategic plan. We've spent a lot of energy around care coordination and care management and practices. We've talked a lot about the dynamic that mental health, undermanaged mental health plays in the care of these patients. And we've talked a lot about can we segment, or can't we risk stratify the population? So I think that there's a couple, 3 years of work just in that, and I don't know the answer, or whether it's a good thing or a bad thing to see the number of Medicare beneficiaries move from the fee-for-service Medicare into Medicare Advantage. But if that's going to happen, it seems to me that we ought to somehow understand that and align with that.
Jack, can you put me on your list?
Yes.
This is Bruce. Put me on the list whenever.
You're on. Yeah, I mean, go ahead.
Okay, I didn't mean to jump the queue at all. I just a couple of things about principles, and triggered to some extent by last comment. If there's one thing that we know as an absolute incontrovertible fact from 30 years of data, it's that Medicare Advantage has never saved the Medicare program a nickel. It is more expensive, and maybe that's why Maryland's performance on total Medicare cost per capita doesn't look worse than it does, because at 9% rather than 30%, you're saving 4 or 5% per beneficiary on the 20% differential. So, but that leads me to the broader question, which is, I think we're at risk of, as we sort of talk about principles and talk about goals and priorities, of confusing ends and means. I mean, better management of care is not the end in itself. Better care is the end in itself. More efficient utilization of resources, substituting primary care or post-acute care for avoidable hospitalizations. Those are the goals. Management structures are the means. And I'm concerned that in all of the turmoil in healthcare in post-ACA, what we have done is created this enormous boon for the non-clinical side of healthcare, and created a gravy train for consultants and MBAs who've never seen a patient and stuff like that, and the actual core of the service and the delivery system is getting lost. So I think it's important not to get hung up on particular structures or particular magic or any of that stuff. We want to talk about is, what is the nature of the clinical services that people are getting, and how do we get them clinical services that are better matched to effectively serving their needs? And those needs can be preventive as well as curative. But that's the goals. This other stuff are intermediate techniques which may or may not help advance the goals, but they're not ends in themselves.
I agree with everything you said except the idea that consultants are doing real well on this. You know, everything else you said is absolutely correct.
For the record, I say that as a consultant.
I know. Yeah, we're in this together, man. Carmela.
Maybe I could put a straw man on the table. I was listening earlier, and I wrote in capital letters some of the big words that have been said today. But this notion of a strategic plan and how we move ahead with the work of this group, I'm torn between the first and the second step. I'll do it in one direction, but maybe invert them. The first big word I wrote was focus. And so I'm thinking about the work of this group out of boiling the ocean. There's a lot we could do. How do we decide? And we've heard Medicare. We've heard it's not let a thousand flowers bloom. How do we have a conversation around focus and what that means for Maryland? The second piece is the data to inform that decision. And I'm torn between, you know, do we spend some time brainstorming on focus first and then apply the data to figure out if we got it right? Or do we have to wait for the data first to then figure out where the focus is? But that data was the second big word I wrote. The third big word I wrote was accountability. And I think the challenge is this notion of how do we create the next round of accountability mechanisms that will mesh with the one we have right now, which is global budgets. And that's the problem with the Medicare bundled payment or whatever the other demos are, dual eligibles and those who are working on that. How does it fit within the structure we have? Because we have a structure whether we like it or not. We've got 5 metrics, we've got global budgets, and we have time. And then the last one I wrote down was just managing the heck out of the time frame. And I might amend that at some risk. We either have to manage to the time frame we've been given or seek to change the time frame to do it well. And I don't know the answer until we get down this course, but I sort of heard this at the last meeting. If anyone doubts the commitment to this model, they haven't seen the time that Donna and her team have put into it, all of these volunteers around this table. I don't think there's a lack of commitment, but if we rush to do this without selecting carefully, we could blow everything that's already gone into this model. So a suggestion for a couple of steps.
Well, very helpful structure. Let me pause and see if either Gary or Dean as I know it's hard when you're not on the phone. If you don't, it's fine. If you're just enjoying listening, that's fine. But if you'd like to jump in, I wanted to give you the chance. Okay. Maybe later.
No, this is Gary.
Gary.
So this is Gary. You know, I was trying to track against, really kind of following up for what Carmela said. I think, obviously, I continued a lot of great comments and a lot of great feedback, but I continue to look for more of how can we kind of get into direction and find out how to, how can we really help. There's a lot of, in Maryland, obviously there's a lot of discussions around ACOs and, first how to come up with a set of quality goals that I think the delivery systems would align with. And then, then really get into the affordability question of how you measure the right price, the right utilization that moves to a triple aim for, for the population we're trying to cover. So I still, make my mind as a direction, if we start to try to, is there a way to kind of go after quality measures that kind of line up across the, the constituents, and then at the same time, if you start to look at the components within medical cost, is there a way to start, measuring what would be, where does those per member month or per member per month costs need to be to meet the targets? And that's a direction that I think might be useful if we start to think about quality, and then, within the segments of medical cost, if we started to get some baselines on utilization rates and cost per unit, to start to look at it that way to make some decisions on how we go in the future. That's that's where I'm coming from.
That's helpful, Gary. Would it be consistent with what you're saying? But tell me if it's not, that you almost seem to call out for looking at, and this is another way of saying what Bruce was saying, another way of implementing it, the breaking down the components of total cost into things like lab work, diagnostics, pharmacy, inpatient care, specialist physician care. Where are we out of line? If that's doable. And you mentioned utilization, but it's also price. And that gets back to, why did CMS pick hip and joint? Well, I don't know, but I'll bet it's because they've seen the data that I've seen from CalPERS and others, that there's 8-to-1, 9-to-1. Colonoscopy is another area. They didn't pick that. David knows all these better than I do. Where there's huge variances in price that cannot be explained by fewer complications. So if you're going to get your hip and knee done, it almost leads you to a reference pricing model, which is controversial. But, we're going to focus on this because we see enormous variance. Is that the kind of thing you're saying, Gary, or did I put words in your mouth?
No, that's where, again, in running the health plan, obviously, looking at your medical costs, but and looking, begin to look in very detail on the different breakouts is something that health plans do day in and day out, and you start to focus on the price point of the unit of service and obviously the utilization, and then do some obvious, comparison to peers locally, regionally, nationally, to try to identify where variance is either too much, too little, not good enough, or where you're leading the market. That's something I think directionally would be helpful. Second to that also is there's probably 40 to 50 quality measures that we could bring to look at, and out of those 40 to 50, there's probably clear enough room in the room for 15 to 20 of them to be identified, that really I think all of us would agree to. Out of the, we don't have to do all 40, but there's probably enough common agreement on 15 or so that would give us all comfort that we're keeping quality in focus. That's just that's a suggestion.
Good, thank you, Bob.
Oh yeah, absolutely. There you go. You don't want this at all?
Not yet.
Thank you. Thank you. I think our biggest risk as a group is not moving fast enough and losing control over the waiver. And what I mean there is it's back to this boiling the ocean discussion here. If you think about Medicare, 6 million people in this state, 900,000 Medicare people, probably 20% of that 900,000 are the high utilizers. So maybe we're into 180, 200,000 people. That's in a very short-term focus. That may be manageable in terms of having a significant impact. So I think keywords are focus, and focus on the high utilizing Medicare folks. Speed to implementation is going to matter. I just can't believe we've got 3 to 5 years here. As much as I believe in health prevention and all that, I tend to agree with David that we'll clock out here. And once we get behind that CMS power curve here in terms of falling behind targets, then the only thing we're left with, and I know it's a trigger I don't think the rate commission wants to pull, is a differential change where we do a cost shift inside the rate system, and it sort of violates all payer principles. But we're into more desperate types of activities. I think we got to, and this isn't something to begin next year. I think it's something to begin now, because whether it's the current waiver or the future one, I think getting at having the maximum impact on the Medicare population speed to implementation is going to matter, because that buys us time to be able to do longer term things. So,
right, thank you. Very helpful.
Just on a related note, so it's good that we have the mic. On a related note, so I agree completely on the focus thing. I think the idea of focusing on, the 20% high utilization on Medicare is exactly the right place. I would just call out that on the duals, there are probably about a little less than 90,000 fully eligible duals on that 900-some thousand Medicare beneficiaries, right? So I think that the interventions, the prevention, flattening the continuum looks, my suspicion based on my life professional experience is that looking at the drivers and the potential change is different when you look at pure Medicare, 200,000 high utilization versus the 88,000, potentially that are the duals, getting to Vinny's point. All really important, but I don't think when we get into the data, I think we're going to see that they are differences that we can make in different ways relative to those two groups. It's not the same group,
I would just throw in, we have a lot of experience saving money and maintaining quality of care in those high-using duals is really difficult, and there's hardly any demonstrated successes. I think the high-cost Medicare people with high acute care expenditures, the interventions you can make are much more plausible.
Yeah.
But the dual, everybody understands the duals are very expensive and so forth, but when you actually look at efforts that have taken place over the last 30 years to save money by better care management, moving people out of institutions to the home, a whole gamut of stuff. We've tried a lot of stuff over the years. PACE, for example, has increased the quality of care very significantly. It doesn't save any money. These folks are intrinsically very expensive to care for, and you can substitute one kind or another and get better outcomes. But if we want to save money, let's look at the Medicare onlys at that 20% of the 900,000 or whatever, because I think the opportunities there are much greater.
Okay. Then,
Jack, if I
I'm sorry.
If I may, just for a second. Yes.
Please.
I'm sort of thinking about this also from a commission perspective, and I think an important principle here is that the commission has always operated on the basis of putting incentives in place, identifying problems, putting the incentives in place, and relying on the delivery system and the health plans in Maryland to develop the solutions. They can identify options, they can provide data. When the day is done, it's the people who are delivering the care and managing the care that will have to be held accountable. And so, I hate to sound like a one-note Johnny, but I do think it's important to understand sort of the financial consequences of different outcomes, and then translating those consequences into their financial and other types of incentives for the industry. But then, we've had a very rich discussion here about ways to save money, but and what the opportunities are. But the fact is that what works on the Eastern Shore is different from what works in suburban D.C. or Western Maryland. Let the delivery system respond to the incentives, place it at risk, but then make sure that they have the resources that they need in order to be successful.
Good point. Thank you. Ben.
Thank you. So in an effort, and I think we talked about this in the last meeting, to not reinvent the wheel or leverage what exists already, there is a program that exists today, the Advantage program, and so why not take a look at some of the quality, the financial, the outcome metrics there, and replicate it? Maybe there's an easier way to gain approval or move it forward more simply, and it's consistent across the market area, and you can compare and contrast Advantage plans against whatever is developed.
Thank you. Kevin, yes.
I would like to take us back to, because I think what we're trying to search for is who's got what role and what should we do first, second, and third. And
yeah.
I think we've got a lot of possibilities on the table. In the interest of maybe a construct, I would go back to the very first report we did a couple of years ago. We described the role of the commission as a regulator and as a catalyst, while also allowing innovation and local flexibility. Those were that was the sweet spot, I think we said. So if you think about regulator, I think we should, because we talk a lot about all the problems, but we should maybe proclaim success for a minute. By going to a global budget, we have taken failing the waiver off the table, actually, because you can set it prospectively to avoid that. It's also been, I think, a catalyst to drive hospital relationships, partnerships with many of the groups we've been talking about, whether it's long-term care, physicians, community groups, consumer groups, insurers. There's a lot more reasons to do that than before. I personally believe we would be a much stronger catalyst by migrating from global budgets to attribution. I think it would do all of the same things except be an even more forceful, have more of a forceful impact on a lot of these other pieces. I think that's one piece. I think in the catalyst piece, this attempt, some things that won't be covered by that. And so where the HSCRC can be helpful, I think they are trying to be, is look for ways to try to drive inter-hospital cooperation and regional partnerships. And some of the grant money is certainly moving in that situation. And in my mind, this data issue, which is the third piece, is both data, so we all could have it, but it's also some of the things Bruce just said. You know, if giving out the best information about what works and what doesn't. You know, because I think hospitals and physicians and everybody else would use it, and because they can only do a couple of things. So maybe they wouldn't chase everything if they knew that one's probably not looking so good. So I would try to start to frame this, and I obviously think the original one is a good one, and I still believe that if we don't leave a lot of room for things to happen that we haven't yet figured out, we will miss the boat. Because it is sobering to hear all the things that have been tried and haven't worked.
Yeah. Don't over-specify.
Yeah, I mean, but because I think we've done some things already to take some risk off the table. The problem we have with it is that it's not a long-term solution. It prevents losing, but it doesn't yet get us to where we win in all the ways we want to long-term.
So thank you, that's great. Could I ask you to help me with one question that always puzzles me a little bit? It flows right from what you're saying. You said migrate from global budget to attribution. It might be also sort of a public, sort of a population health thing. And I'd be interested if you or somebody else can help me think, again, not in the weeds, what are the one or two most important things that would need to be done to do that? When I
assigning patients to whatever the aggregates you're going to use and getting a good risk adjuster. Those are the two things that would come to my mind.
Yeah,
and maybe to help as a contrast, just a reminder that many people know this, but not everybody, that today the global budgets are applied to an organization, but you are required to care for everyone who comes, regardless. So the notion is attribution is the contrast to that.
I wouldn't go quite so far as say it's a contrast, because I would not change that. To say you don't care for everybody who comes, I think is not what we're talking about. I mean, we're not talking about a closed HMO model. That is not feasible in my mind anyway, and I don't think it would be desirable. But I do think you are talking about, at least as the ACOs do it, owning them at least in some kind of a construct, and maybe it's even after the fact, but some way to assign so that you can do a better job.
So I guess the question I had was, if I'm a patient and the first time a problem comes up, I go to this care system. The second time a problem comes up, I go to another care system. How do you attribute?
Yeah, well, that's now that's complicated.
Yeah.
But let's start with 80% of the people don't do that.
Yeah. Okay.
That's what the data say.
Yeah, okay.
So, we're a long way already there.
Right.
And I think there's some things we
path toward that.
A path,
you wouldn't get all.
And I don't think you'll get this right exactly.
Yeah.
It'll take some time, but the really, it's more. Someone said be worried about the outcomes. I think that you want to try to drive the behavior that's best. And there's still some aspects where we are now. We don't drive all the best behavior. We've changed for the better, and we've given ourselves some comfort against the waiver. But there's still room to make the behaviors even more aligned, I think. I don't have all I'm not suggesting I know exactly how to do it, but I think that's making it easier to come out with the way we'd like it to come out.
Yeah, and don't make the perfect the enemy of the good. Move in that direction, refine, adjust.
I would.
Yeah, that's very helpful.
Jack?
Yeah, yes, Eric and then Willarda. Thank you. Yeah, I want to say something. Willarda's my deputy.
Willarda, I owe you something now. For
Yeah,
certain.
I get so into listening to somebody on this side. I apologize.
I know. I mean, they're very articulate, so it's easy to be focused there. I hadn't intended. I mean, this wasn't going to be my line of comment. I'll come back to a couple things I wanted to add, but I'm not where Kevin is. I think it's premature for us to think about moving off of global budgets and into an attribution model. And I certainly understand all the points that Kevin makes. And in an ideal world, there is more certainty about it. And it gets at the issue that we've touched on a couple of times, the accountability issue. Who is accountable? But I don't actually think that it explains 80% of stuff. I mean, as now a recipient of this data, it is actually amazing how many different places people go and how much kind of threadedness or interrelatedness there is. And I just don't think it's particularly practical, particularly when you're in a marketplace where there's a number of hospitals. So it's too early. The other comment I would make is if it's a belief that that's a good model, there is actually a mechanism to do that right now, and it's to have an ACO, which you can allow Medicare to do the attribution for you, and there you've got your data, and you know who that population is that you're going to work with. The 2 points, though, that I wanted to make, one of which is to come back to the comment, and Jack, you said something about reference pricing. I think it was in response to what Gary Simmons was saying. I think we have to be awfully cautious about that because of the social determinants of health. And there is really, I mean, we're in the infancy in terms of the ability to adjust for those things. People have touched on the fact that Bob Krenzik and they not only serve a different set of patients, they provide a different scope of services, and I don't know that we've really found a good mechanism to adjust for that when we're saying, why is this provider more expensive than this other provider? And until we can do that, there's places in the country where we are absolutely disadvantaging the safety net hospitals because nobody is making those adequate adjustments. They look bad on quality and they can't get their incentive payments out of Medicare or they get penalized. We really have to be very cautious, and perhaps we in Maryland could be leaders in that realm as well to suggest some things that help with that. The other point that we haven't touched on, and maybe because it's a little bit of the third rail, is end-of-life care. Joe and I had a little sidebar in terms of, how expensive the last year of life is for people who are on Medicare. I'm going to bring it to a more personal level, which is a couple of family members who, over the course of the last 12 months, have passed from this world. And my experience in watching how that process unfolded as not a healthcare professional, but as a family member, and not in Maryland, but we do an appalling job, I'm going to say, as a healthcare industry in terms of serving the needs of those patients and their families and really making them aware of what their options are as they enter that phase of their life, or being honest with them about where they are in that phase of life. And the data, I guess, kind of suggests that maybe we're not in a good spot on that, because if our hospice utilization in Maryland is less than what it is nationally, we're probably doing an even worse job. But in my case, those two family members both entered hospice in the last week of their life. In both instances, they should have been in it 4 months earlier. And their families and they would have made very different decisions about the course of their care, which coincidentally would have been much less expensive. But in the context of my remarks, it's not about how expensive it was. It's about what the quality of their life was for that last 4 months. And so I hope that in some way, and it's probably a third rail because we hear, the stupid talk about death panels. And that's not what this is about. This isn't actually about cost. It is actually about better quality of life, and that is what we should all be about. And I would hope somehow we can incorporate that into our conversation.
Thank you. Atul Gawande's written a gripping book about this with many patient stories, and you're absolutely right, Lenny.
So that was a great segue. Thank you. I'm just looking around the table and thinking I'm probably the only one on Medicare here. I had the same experiences some years ago with my parents, and this was an issue that the Consumer Engagement Task Force addressed in our report. And that takes me to the fact that I've been sitting here looking at person-centered the entire time. And if we could just make sure that, in fact, the person is at the center of this, and as looking at models going forward, thinking always about what the impact is, and the fact that we're needing to meet the metrics of the waiver, but those metrics may not always be in the best interest of the individual. And so I just think we have to contemplate that and take that in as a factor. Also, to go back to the strategic planning thing, I'm really sorry, but I was a consultant for many years for nonprofits on strategic planning, and that was really a poorly paid field. So now I do this as a volunteer, so it's just about equal, right? But, with a strategic plan, you really do start with a vision and mission, which, again, the Consumer Engagement Task Force came up with, and you think I could recite it word for word, but I can't at this point. I'm actually not sure what the mission is here. I mean, is the mission to meet the waiver metrics? But that mission should drive those principles, and from those principles should come those goals, and from those goals should come those strategic steps, right? So I'm not entirely clear about how all of this is actually meshing together, but at the end of the day, I want that person in the center of it, and I want that evaluated as far as impact of the steps that are being taken.
Well, and the waiver metrics are, the big picture is better care, better health, and lowering the increase in spending. So it really, the new waiver is different than the old waiver in that it focuses on care and health and not just spending, and so that is part of the force of going forward. I wanted to say one thing about the global model and attribution, and reflect on something that I learned in the 90s when people were trying to change delivery systems and take on managed care. And one of the things that I learned is that you really need to have people focus on improving what they have an opportunity to actually improve. And so one of the things, if we take a small hospital, so I'm just going to pick, say, a small hospital that really doesn't, that only provides a portion of the services to a population, and then we saddle them with an ACO, there's an awful lot that they actually have very little capability to influence or control in that situation. But that hospital has a lot of capability to influence what they're doing in their hospital and what they're doing with the post-acute and long-term care providers in their medical neighborhood and what they're doing with their primary care doctors. So the thing that you can take from that is if we can construct a model that is around the neighborhood, the global budget, and the geographic area, that we may be able to develop something that the provider has a significant ability to influence and control, not to the exclusion of an ACO, which some providers may have the ability to manage and control, but a lot of providers really don't have that. And in the end, if we're running with time and we're trying to get control over the larger areas, the regional partnerships are focused on areas, and if Peggy could focus on her area with the data for her area and be able to do that in a more global way, focusing on your population and your service area with a full set of data, that might be something that we can, begin to tackle and move forward with. That would be kind of a unique model that could go along with the Maryland global model, the geographic model with the global model, along with not eliminating the ACOs, but it's something that could work side by side. Because at the end of the day, every model that's coming forward in the state, the Medicare Advantage or the ACO or the hospital global budget with a geographic service area, everybody needs the same outcomes to be delivered in terms of driving better care and better relationships with primary care and hospitals and long-term and hospitals and really getting the care outside of the hospital. So if we can figure that out, and then I think that potentially brings something else to the table, and that ties into what Carmela and Jean have been working on with the potential savings models and tools from Medicare to be able to get data in the geographic areas and potentially be able to start to create some relationships and partnerships in geographic areas and around hospitals and around, not just around hospitals, but around communities.
Great. Well, this has been a great discussion. I'm just about ready to segue to Vinny. Bruce, are you still on? I might have lost Bruce. Okay. I had a comment for him, but is there any quick, because we only have 2 minutes, if somebody feels a thought they didn't get a chance to express, this would be the time to do it before we move to Vinny and then public comment. Okay. I've gotten an awful lot, we've gotten an awful lot of ideas. Thank you. I mean, you really responded to my challenge of prioritizing and steps, and you're. Oh, I would love it. I noticed you've been taking notes, prolific notes, so I would love it. Yeah. So we're going to move to Vinny, who's going to tell us about his great event. Vinny, I'll have to ask you to make it about 10 minutes or so, and so we can get the public in. But the floor is yours.
Thank you, Jack, very, very much. This Monday's launch of the Faith Community Health Network pilot project with LifeBridge was a huge success. Starting with a front page article in the Baltimore Sun, and I'm showing you all the page with the beautiful picture in Monday's Baltimore Sun, and I've given everybody the packet that includes the article, and my colleague Matt has some others if anybody in the audience wants a packet. In addition to the front page article, in which there was a great quote by Carmela, thank you very much, there was an op-ed, a lead op-ed in the Sun by myself, Neil Meltzer from LifeBridge, and a top faith leader describing the Maryland Faith Community Health Network. So we started with that. And even more exciting was the fact that despite the fact that it was a bad snow day, and you'll all remember everything in Baltimore that wasn't already closed for President's Day was closed, we had 75 faith leaders brave that weather to come to Pearlstone Center to be part of this launch. And we were just so excited about that. So it was a big day for the Maryland Faith Community Health Network. So I have a short PowerPoint, and can we go to the first slide? Am I working it, or? Do you want to, or do you want me to? Whatever. Oh, is it right here? I think I can handle it. Okay. Is it this? Maybe I can't handle it. It's that. Which button do I press? Oh, there we go. Okay, thank you. So as you know, the Faith Community Health Network was inspired by the success of Methodist Lebanon Hospital's Congregational Health Network. And as we talked about last time, this is a program that has proven success in reducing mortality and morbidity amongst people who are in the populations we've all been talking about. So we do have success here, and we were thrilled that LifeBridge wanted to pilot this program here in Maryland. Oh, wrong way. Maybe you should do it for me. Okay. Okay. So sorry about that. Good try. My sons will not be surprised. So if we can go to, did I mess it up? I don't know. Okay.
Right, there we go.
All right, good. Thank you. So we work closely with LifeBridge staff and local faith leaders to create a memorandum of understanding between the hospital, our organization, Maryland Citizen Health Initiative, and local faith leaders to implement this program. And very importantly, the congregations were deeply involved in creating the program. Next slide. What you see here is the memorandum of understanding. Now, I have emailed this to everyone, so if you want to look at it more detail. But this memorandum of understanding commits the hospital to provide support for these liaisons, and it commits the congregation to identify liaisons who will work with the hospital to keep people healthy. So it's very, very important that this memorandum of understanding is the beginning of the project, and later on I'll show you a list of 39 congregations that have already signed this in the LifeBridge area, have identified liaisons, and are working with us to make this happen. Next is my favorite slide. This is the picture at Pearlstone Center in Baltimore County of over 75 faith leaders and people from LifeBridge coming together to make this work. And it was, to me, the diversity, the strength of this group, this is consumer outreach and engagement. This is the people of Maryland coming together to make health system transformation work. And I do love that picture. In the next slide, what we did on Monday was an intensive training of these liaisons, beginning with a discussion about faith and health by people from St. Mary's Seminary, who talked about how important it is to people who are ill to have this faith support. Then there was an intensive training by LifeBridge staff, and I just love LifeBridge, and the whole staff are doing a great job with us on this project, really talking about how the congregation and the hospital interact to keep people healthy. And we help with the liaisons to talk about self-care and management of health ministries. And then a very important element, we had people from the Maryland Health Benefit Exchange there educating the liaisons on how to make sure that everybody in their congregation is enrolled in the Affordable Care Act who's eligible. And this is a way in which what we're doing is built on different than what's happening in Memphis. Because in addition to helping people when they go into the hospital, we're working to make sure that in these congregations people are healthy and never go to the hospital. And we're doing that by getting them insured, and related to comments earlier that I made, making sure that we improve public health in these congregations. We're going to create a toolkit that's going to help the people in these congregations, help someone in their congregation who just can't stop smoking. Well, there's a state agency that can help them. Someone is turning 50 and doesn't know that there are things like colonoscopies that will help keep them healthy and reduce healthcare costs for all of us. We want people in these congregations to know how to stay healthy, and these liaisons will help us do that. So that training built on this. What we're going to do going forward is have a monthly call-in for these liaisons where they will work with us to educate each other and learn more about how to keep people in these congregations healthy, both before and after they, and keep them out of the hospital. If they go in the hospital, keep them from going back in. In the next slide, you see, in addition to the training, we had a press conference. I want to thank Carmela for being there for the press conference, and the media coverage was amazing, which in addition to the front page article in the Sun and the op-ed, there was a BAL TV piece, which was really beautiful, in which you'll see Reverend Sherry McCourt, who was featured in that piece, talking about how important this is, this Faith Community Health Network, to help these congregations keep people healthy. Congregations have been doing work like this for decades or centuries, but now they have support. This will dramatically improve their ability to keep people healthy. Also, there was a piece in the Associated Press, which was covered not only across Maryland, but across the country, from San Francisco to Virginia, Kentucky, everywhere. Newspapers took this up. And Carmela, you don't know this yet. I just got it by email. There's a big article in the Baltimore Jewish Times with a picture that's here, you see in that collage of all of us in front of the banner with Carmela speaking and the faith leaders and everyone else behind her. So the media coverage was really substantial, and that's important because we believe that the Maryland Faith Community Health Network is a great way for the health system transformation to be translated to the general public. You can't talk to the general public about global budgets or the wonderful things we've been talking about here, but you can talk to them about hospitals and congregations working together to keep people healthy. That, I believe, is the best way for us to communicate with the public. That should be the way I think that health system transformation is explained to the people of Maryland. The next slide shows you the list of the 39 congregations, which is already, we just started a couple months ago. And one of the reasons this has been successful is that virtually all of the top faith leaders in Maryland, starting with Bishop Dennis Madden of the Catholic Church, the Baltimore Jewish Council, the Episcopal Church, the Methodist Church, the top state faith leaders wrote a letter to all of their congregations within the Lethbridge area urging them to participate. And I got a call from St. John's Catholic Church in Westminster that said, we got a note from Bishop Madden said we should do this, and we're doing it. And that is something, next slide, which we believe can happen all across the state of Maryland. So what are our next steps? We have, as part of the grants we received, contracted with University of Maryland School of Pharmacy Patients Program to do an in-depth evaluation of this program. This is a 2-year pilot. We're going to have a lot of evaluations. In 2 years, you can't really get a lot of data on readmissions, et cetera. But our experts at University of Maryland are going to devise ways to test metrics which will reach reducing readmission. They will test how the liaisons and the patients work together. What are they seeing at the hospital? Metrics which we believe in a couple of years will be very, very helpful. We are launching this network right now, and we've identified 10 congregations which are, as we speak, working with us and Lethbridge to make this work. In a couple months, we'll have another training. We'll learn from these 10 congregations, and then we're going to expand it to the other congregations which have signed memorandum of understanding. We're doing this slowly but surely, and I think effectively. And finally, we want to work closely with Carmela and the Maryland Hospital Association to explain this to other hospitals. And I'll tell you, one of our best advocates is going to be Neil Meltzer of Lethbridge. He loves this program, and he said to me, just let me help you explain this to other hospitals. And one of the ways we're going to do that is in the fall, we are going to host, we had successful forums, as you know, last year. In the fall, we're going to host another series of forums across the state. They're going to be co-sponsored by the Maryland Citizens Health Initiative, the Maryland Hospital Association, and the NAACP. The three of us are going to hold forums from one end of the state to the other to explain where health system transformation is, to talk about the Faith Community Health Network, and to engage the public again, as we did last time, in what are their thoughts on how best to make this work better. So let me just say, I love the Faith Community Health Network. I think it is a program that is going to, number one, achieve the 3 goals of health system transformation, and I believe can be the best public face of what we're doing.
Thank you, Vinny. Great. Your enthusiasm is high, and it always is high.
Thank you.
And thank you for what you do. If people want to ask questions after the meeting, if you have time,
I'm not going anywhere.
Stay around for a while. Vinny can certainly chat with you. Just to keep us on schedule, it's now time to see if any of you who've been listening for the last 2 3/4 hours want to, pardon? Who lasted, yeah, bless you, have either a question or a comment with your own
Thank you, Jack. I'm Mike Robbins with the Maryland Hospital Association, and I just wanted to pick up one of the items that Kevin talked about in the discussion around guiding principles, and that is the principle with regard to innovation. I think it's important for us to keep, as we're talking about, what kind of common outcome measures and allowing for flexibility in the system, keep reminding ourselves that there are new ideas, new things coming into the healthcare delivery system each and every day. And we need to always find a way to allow for that innovation. Innovation in new drugs, new technologies, new procedures, new way of providing healthcare. And so I just wanted to underline how important it is. We talked about that 2 years ago in the original report of the Advisory Council, that we send the message through the work and the report of this council that we will always want to find ways as we look for common goals and common programs and measures, at the same time allowing for as much innovation in the system as we can accommodate. Thank you.
It's an interesting, very interesting and helpful point, Mike, because there's always some tension between cost control and innovation that people don't want to talk about, but it's there, and it's a helpful reminder. Anyone else like to chime in and make a comment? Oh, I'm sorry. Yes, please. And just identify yourself if you would.
Hi, good afternoon. My name is Jen Brock Cancellieri, and I work with 1199 SEIU, the United Healthcare Workers East. And sort of, I guess, building on that point, and a lot of the conversation that was made today, I appreciated Peggy talking about the strategic plan. One of the conversations we're interested in this advisory council exploring is looking geographically across the state as healthcare delivery is transforming and changing delivery from hospitals to outside of hospitals. We hope there'll be a comprehensive plan or vision about geography and when hospitals may need to be transitioning to not being hospitals, where is that happening geographically, and how does that relate to the services, the critical services that need to be provided? And then also looking at the folks that are choosing to make their living delivering this care and the jobs that they have, and as jobs are transforming in healthcare as well, is there a bigger picture plan to provide the appropriate training to the folks that might be not needed in hospitals as healthcare is transforming, and getting them adequate training that they would need to move up the healthcare delivery career ladder? So those are conversations, just points to be made, as hopefully to get on the agenda for this body to discuss.
Thank you. You know, it's an important point in healthcare, but also in our economy generally, where there are tectonic shifts that happen, and people sometimes forget about the impact on the workforce, and they get into some crazy arguments sometimes, which I'm sure you've heard all of them, when a lot of good common sense says allow some of these progressive efficiency things to go forward, but don't forget about helping people who are dislocated, or and helping them retrain, move, you know, so that they can make the transition. So it's a very helpful point. I hadn't thought of it in this case. I'm a labor economist. I used to think about these things all the time, but not in this case. So I appreciate the reminder. Lenny. Sure.
So we have a person-centered model. It's not a patient-centered model. So perhaps if we thought in broader terms about person, that might speak to Jen's point.
Yes, that's a good way to put it. The persons are not always patients. That sometimes it's the people that are helping the patients and delivering the care. Yes.
And on the demand side, you know, when Ben and I were sitting, in terms of the training, Ben and I were sitting in a meeting, and the physicians in the meeting were saying how much they needed a workforce to be trained, medical assistants with IT skills, as you know, for example, as a part of the workforce that needed to be really trained to help make the delivery system capable in the community. So I think the the training issues are definitely there in multiple areas. So it's not just about displacement. It's about getting workforce trained to be able to deliver in a different way.
Yeah, that's a good point. We need a workforce that meets the needs that we're outlining at our level. Who's going to really do that, and do we have enough of them, and so on. Well taken. Anything else? Yeah, Bob.
Hi, Bob Atlas. I'm a consultant to the Medicaid agency, and I just was thinking about Bruce Vladek's remark of earlier in which he said, effectively, don't worry, don't focus on the dual eligibles because nothing in the last 30 years has worked. We're the agency with a CMMI SIM grant along in partnership with HSCRC and many stakeholders will be looking for solutions, and I hope you don't take that comment as shutting the door. I think we have an opportunity to do something, to use a word that's been used a lot today, innovative and different, building on what some other states have tried to do. So since you're taking such good notes, I wanted something in the record that would counter that sentiment, especially since Bruce has a way of emphasizing what he says.
Yes,
I mean, I think we're already doing a lot of things with the dual eligibles, with Carmela's work, with the long-term care facilities. So I think there's a lot of good things already started, and I'm a believer that we're doing some good stuff from a lot of the things I'm hearing, and that we can make progress. It's a different. We're at a different point and a different time, and we have a different opportunity. So I'm not discouraged either, and I think we can do more things successfully for dual eligible persons.
Yeah, I agree, Bob. And we've both worked with colleagues who have been working on this for years, and they've come up with some good ideas. They're working with states. Not everything works, but some things do. And it's a special population with needs that go well beyond the medical model. So I'm glad that you duly noted in my notes. Thank you very much. Anybody else? I think we're done. Except at the next meeting. Oh yeah, the one important task of a facilitator. March 25th, I believe. Oh, 21st. Yeah, I didn't get that right. Don't rely on me. March 21st is our next meeting. Steve, do you have the time? I'm not sure. 12 noon. Kim, yeah. Okay, thank you. It takes a village to get me to do this right. March 21st, 12 noon here. Thank you. This has been an interesting meeting, and you all worked very hard. Have a good weekend.
Thank you.
Thank you.
Back to Good. I'm working on it. I'm actually working on it.